A little different, maybe a little different perspective. So my goal is to provide you with a provider's perspective. And by that, I mean a grassroots provider. You know, I'm still in practice. I still do plenty of surgery. And I think the other part is the patient and family perspective. And I hope, as you'll see, is if we return back to our mission, we may also have the ability to change the system itself. So just some overriding. You know, when you're a provider, it's all about patients, teams, and value. By patients, we mean we have to view care as an experience, but through the eyes of our patients and families, and not us, our systems. Secondly, it's become very clear that we have to drive transformational change. And you know, we used to use disruptive change, Jessica, but in healthcare, that's not such a good term when you're at a grassroots level. But transformational change will only happen if you could couple very tightly clinical and financial performance. And that the patient, if you have that patient focus, it provides the how to achieve value. And the how to is improving experiences and outcomes while reducing costs. So you've heard over and over, you know, we're in this dramatic change. And I think all of us will agree to that. But one of the things in healthcare that we don't provide grassroots providers is the how-to tools to get there. You know, if you think about it, you can even use clinical best practices as an example. You know, there's lots of best practices out there, but how many times doesn't it take root? How many times doesn't it get traction? And most of the time it's because we don't provide tools to the providers to go from their current state to that best practice. So one of the themes, too, that you'll see from what I'm going to talk about is many of the themes come from other industries. You know, as we've heard already, although healthcare has sort of always been over here, as Jamie said, there are many lessons we can learn from healthcare. One of the most important lessons that I've seen over and over is that no industry can survive without focusing on the needs and wants of their end users. And in the end, our end users are our patients and families. So we must begin to understand their needs. And again, you just have to go back to basics and ask our patients and families and the system in which we provide the care. Now, how many in the audience has either been a patient themselves or a family member of a patient in the last 6 months? Like 90%. So of you that had a care experience, how many of you would have defined it as ideal? And that could be any definition, but it's your definition. How many have said it was the ideal experience? None. One. So of you that had the experience, how many of you came away with ideas on how to make it a better experience? Probably 80% of that. So how many of you came back on Monday and changed the system? No one. And we're the experts. We're the experts of the system. The other theme with this is that all of us, and particularly in leadership, forget that we're also patients and family members. We're also consumers, and there's a wealth of information to learn from that if you can channel it in the right direction. So what I'd like to propose is the theme of a patient-centered value system. And this is truly a disruptive approach to the current system that we work in. But the theme is, if you have the patient at the center and understand what's value to them, you could connect all the buckets that we've looked at: outcomes, experience, and now cost. So there's 3 keys to develop a value system. A value system, number one, you've heard it already, is you have to view all care through the eyes of patients and families, and you have to call it an experience, not a service line. An experience means that you cover a full cycle of care. One of our patients say, in my situation, they don't separate out the hospital experience from the whole experience, from diagnosis, treatment, and recovery. So you have to, it forces us to look at this full cycle of care, which is what we want to do. Number 2 is it's a concept called co-design. Now, we haven't used this necessarily in healthcare, but it's used every day in other industries, from engineering, architecture, service industry, everything else. So co-design is really how do you engage your end user in the process. So we do have some very primitive forms of co-design, which is service recovery. Hopefully we listen to our end users and hopefully we respond to them. Maybe we can even change the system a little bit. The next level is what we call advisory councils, where you have your end users actually act as a consultant board to help you design systems. But the third and most mature version of co-design is called experience-based co-design. And the reason for that is it fully engages your end user in the design of the system. They are your partner in designing the system, not just a customer. Now, on the clinical side, it's very important to do this. There is so much literature out there that shows that the more engaged or activated a patient has in their own care, the better outcomes they get, over and over. So you think about it, not only can we develop a system, but we could actually engage patients in their own care to improve their outcomes and to design the system to continue that. Number 3, it gets back to this, I call it the implementation phase. It's the how-to. You have to understand that this is a disruptive process, and there's certain challenges when you have a trying to introduce disruptive processes into existing organizations. First of all, one of the biggest challenges is you have to determine your current state. Everyone's current state is different. Even within one hospital or one office, the current state could be different. If you're going to drive change, you have to determine your current state. The second part is you have to determine, well, what's the ideal? What's our goal? And the only way to achieve that is to engage your end user in helping you define what's value. But then, probably, again, importantly, is a methodology that builds the teams, that's reproducible, it's simple to follow, and overcomes the hurdles, the expected hurdles, because this is going to be a disruptive process to care delivery. And that was the basics of a methodology we developed 8 years ago now called the Patient and Family-Centered Care Methodology in Practice. So the theme was you go and determine your current state, you build the care teams, and you drive towards the ideal. You just follow these steps. Now, for instance, the first step is a care experience. And that can be as narrow as an office visit in a primary care office, or it can be as broad as a level 1 trauma experience that happens from the first call in the field to the time they go home. Or I'll talk about our care experience, which is a month before surgery to 3 months after surgery. But it could be any care experience in between. Then you develop a small strategic council. I'll talk about a tool we developed called shadowing, in which you determine your current state and care experience flow maps, but you also generate this sense of urgency because it forces everyone to look at care through the eyes of patients and families. You develop very unique teams, and we'll call them care teams, but these teams are completely different teams than what we've talked about in the past, and the only requirement for membership of the team is you represent a touch point on that patient's or family's experience. So many of our teams go from the parking person to the VP of Ops and everyone in between. Next, you develop the shared vision of the ideal. And lastly, it's get to work, close the gap. And that's the basis of the methodology. And it's a reproducible methodology for any care experience. For you in the business world, like any kinds of innovation, it's built on other people's work. So these all are the business leaders that we took tools from them and applied it to this methodology. So Clayton Christensen, Innovator's Dilemma, how to introduce disruptive processes or technologies into existing organizations. John Cotter, developing sense of urgency, breaking down silos. Pine and Gilmore on the experience-based economy. Brown from IDEO on the West Coast on developing direct observations. Denning on storytelling. Kaplan and Porter, who I'll talk about, on the value structure and tools to determine cost. And actually a local connection, Herb Simon. Everyone familiar with Herb Simon? So he was a professor at CMU in economics. He won the Nobel Prize for the whole area called the design sciences, which is what this is based on. And the reason that's important, when you start talking about experience-based design as a science, and it's true science, this comes from their definition, not healthcare, but think about how appropriate it is for us. So it's designing services, interactions, processes, and environments for the complete experience. It's making it better for the end user. And the strength of a design science is implementation in the how-to. And there's a great article from Bates in the UK that talks about how the design sciences should be the third science for healthcare, the first two being clinical science and process science. So why can't we many times introduce best practices of these processes? So we all talk about silos. Silos are like enemy number one, right? But we have to remember there's a history behind the silos. I mean, silos didn't develop just to be a silo. It's because of the way our system developed. And until you understand that, it's hard to break down silos. You have to look for common denominators across the silos. And that's basically what we do with having the patient and family as a focus. It's not only a team builder, but it starts to break down the silos. So this is a schematic, but you could use this for any organizations. So I'll use it just now for a hospital. You know, a hospital has two different kinds of silos. It has the vertical silos, which is like the doctor silo, the nurse silo, you know, the purchase supply chain, all that. There's also top to down, top to bottom silos from the C-suite to the people that deliver care. And what happens when you use the common denominator of the patient, you cut these swaths across your organization and the teams that I was talking about that work together in very different ways. And it turns out from the business world is to drive true transformational change, you don't have to have 100% buy-in. In fact, if you think you need 100% buy-in, you'll be frustrated and you'll fail. Industries have shown us if you get about 15 to 20% of your caregivers, of your employees, to become part of this process, you can drive change. There's one restriction or one recommendation on that, though, is that 15 to 20% have to be called what are called evangelists. They have to live and die by their vision. And the way we can activate healthcare is to get back to our mission on taking care of patients and families. So what happens when you have the patient as the focus, you can aim and deliver ideal care and experiences. It does not cost a single cent more. The challenge is to take existing resources and refocus them. But all the resources, including patients and families, are within your organizations to do this. And most importantly, now you partner with patients and families so you can identify problems that are important to them as well as you. And not only identify them, come up with solutions. So one of I think this wasn't something we started out with, but it's a subtle, but I think a very important point. Our mission, taking care of patients and family, will be the focus to drive transformation. Now think about that for a minute, because it's not so clear, but I always use Alcoa experience in Pittsburgh, right? That's a famous case study. And Alcoa, obviously when Paul O'Neill started, he was brand new, and of course, any CEO, he could have picked 10 different themes to focus his attention. And what did he pick? Safety. So first of all, you say, well, what does safety have anything to do with making aluminum? Nothing. But to his credit, he had a passion for safety, but then he also gave his teams tools to go from what they were currently doing to the ideal. And using that, he drove tremendous change within the organization and profitability. So the unique thing we have in healthcare is, unlike any other industry, and I have not found an industry yet, is the mission coincides with the change agent. That's a benefit we have to help really drive change. And PFCC, as a methodology, we have exported it to over 70 different care experience working groups. And this isn't just inpatient. We have an outpatient mental health group that's adopted this. It's from cancer care, ICU experience, family health. It can cover the whole spectrum. There's over 200 project teams over the last several years. And I'm not putting this up, I'm putting up more to show it works. I will say we have a long way to go before we change the culture, which is the ultimate goal. But we also have exported this nationally and internationally. We have 27 sites across the United States, and we actually have 7 international. The most important has been the National Health Service in England, has been a very early adopter of this. So again, think of it as a tool and a methodology that can address your specific patient's needs. That's how you customize the system. The other benefit of that is if you think of it as it's experience-based design, you could actually substitute whatever you want for patients and families. You could substitute it for my employee's experience in selecting insurance. Or you could select it for workman comp experience for back pain. So it's the same methodology because you have to define the experience, and then you follow the same exact steps. So that shifts us now into the value equation, and value in healthcare has become a bit of a cliche, but it's certainly a very, very important topic, but we really have to put some teeth to it. So this comes from Porter and others too, but Dr. Porter from Harvard Business School and Kaplan have been a proponent of this for healthcare. So value is outcomes, and it has to be outcomes important to patients over cost, and it has to be true cost. So a question for the audience, how do you determine value? And I would say if you're an employer providing insurance, your definition is going to be different than if me as a physician taking care of patients, to a health plan that has to deal with certain other factors. We all have our own definition of value, but the nice thing with this approach is in the end, it's your end user. So value has to be defined by your patient and family in partnership with you. This really struck home to me because I think any clinician in the audience, there is a disconnect between what we define as outcomes and improved outcomes, and then you turn around and talk to the patient and say, what was their outcome? So for instance, if I do all my measures, well, what we do, and we have a very robust outcomes program, and we say that was a great outcome, and then someone turn around and ask that question to the patient, many times they don't coincide. So I'm not saying leave behind our outcomes, quality, safety part, but again, if you're going to engage your end user, you have to have different tools to understand what's valuable to them. So in the good step, we've actually moved from satisfaction to experiences, and that's what the whole HCAHPS part was. And HCAHPS are mainly used for inpatient, but they're expanding into outpatient. So that's a trend, but there's another step that we have to take, and it's called patient-reported outcomes. So patient-reported outcomes, as defined by the National Quality Forum, is any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. It's asking the patient, instead of me saying the range of motion of the knee after knee replacement was 0 to 120 degrees, it's asking the patient, can you climb stairs 1/1 without any difficulty whatsoever? It's a completely different mindset. And there are tools to implement this. There's a whole body of literature that's just beginning to come into healthcare as validated tools. And the most important thing, it flips the question. It flips the question and it says, what matters to you as a patient and family, not what matters to me. So you learn about what patients care about, but also, again, it broadens our experience to the full cycle. So it doesn't include any pre and post type of care. And what we have found is we're part of a study up at UMass, and we've been collecting patient-reported outcomes for over couple years now. We're actually looking at how can you use patient-reported outcomes as a shared decision-making tool to help guide us in the decision, is it time for a patient to have hip or knee replacement? So think about it. In the past, we've used these outcomes to say how good we're doing. But now you can feed that information back and look at utilization questions and educating patients in their own outcomes as well. So how many people have heard of the Net Promoter Score here? Few. So this is something, again, comes from other industries. It's an amazingly simple tool, and it gets back to what a lot of the faculty has said. We think our patients are immersed just in healthcare, but they're immersed in the economy, the world that we all live. of which healthcare is a part. So we get compared to everything else. So the nice thing with this Net Promoter Score, and the papers listed below, is you could ask one question, and we ask our patients, how likely are you to recommend us to family and friends? And they have a very simple formula to compare what I call evangelist and they call detractor, the two ends of the spectrum. And the nice thing, it comes up with one score. It's a validated tool, and it also then begins to allow you to be compared to our competitors in other industries. So these are actually published Net Promoter Scores for other industries, from Nationwide Insurance up to Apple. And this is the world that our patients are in. This is another kind of patient-reported outcome, and very simple to collect. And you can see what we found for our Bone and Joint Center and for the kind of work we do, we're in 95 above most any other industry. Now, I'm not saying that to brag, but I am saying that if we're not up that high in taking care of our own patients, there's a problem. If we're even down at Apple, there's a problem. So we need to begin to collect this kind of information. And as I said, we have a very robust outcomes program, but if I had to restart from scratch an outcomes program, I would do patient-reported outcomes first and Net Promoter Scores. And they're very simple to do. So that gives us, so we have some idea what value is. We have a definition of outcomes, but the big black box has been, as you heard, cost. And now we're talking about true cost. And I won't go through this. This is the cycle that we all go through, and the patient's way out in left field about what they really pay for. So Rob D. Maché and his group have developed a very unique cost management system that's a top-down effort. And we've been collaborating with Don Riefner and his team and Rob. Excuse me. And one of the thing that came out of the collaboration is this is one of the first top-down cost accounting systems that uses the patient to determine cost. Because they follow the patient through their experience and they pull all the financial data from each silo that's been created over the years. So what we wanted to do was complement that top-down with a bottom-up effort. Because one of the things that's, again, most important is for providers, we have to tightly couple clinical performance and financial performance to drive change. So we adopted, it was actually, I mentioned Bob Kaplan was our keynote here from Harvard Business School. He developed a cost accounting system called time-driven activity-based costing. And basically, you can determine in 4 buckets the true cost now, the true cost to deliver care over a full cycle of care. The benefit of this is using the patient again. We found the patient is the connector between all this. It's based on actual clinical, administrative, and back office processes. And it really helps you identify all resources to deliver a specific care experience, or they call it a clinical condition. So when we first started this, it could be daunting, right, to think about all the touch points and all the care providers and all the places they get care. And we were going to look at our bundle, which is a month before to 3 months after, so I'll talk a little bit more about that. But again, it became clear you just go back to the basics. The patient and family is the only connector between all of those. So we applied a shadowing tool we called that we were already using in the PFCC methodology in practice as the way to collect the data for determining the true cause. Now shadowing, it's not a secret shopper by any means. It's a very open process. But it's the repeated real-time observation of patients and families as they move through each step of their healthcare journey. So the basic idea is we have a shadower, and usually it can be anyone. We have student nurses, college kids, we have physicians, administrators. It could be anyone. But they become part of the patient and family as they go through their care experience. And the wealth of objective and subjective information gives you so much to work on. So by shadowing the patient, it cuts across all the silos, so it determines your current state, which, as we talked about, is very important. It accurately collects and efficiently data needed to measure your true costs at a grassroots level. You get the added benefit if it continually engages your end user in real time, because we're always getting feedback from the patient and family that drives further change. And remember, this is done repeatedly, over and over, different segments. You develop what is called a hassle map in other areas. Hassle maps are when the system doesn't meet your customer's needs, and every time there's a gap, that's an opportunity for improvement, new products, new services. And probably most importantly, we found that this is the way you build implementation teams, the teams that's going to take all that information and make change. The added benefit, which we didn't really predict, but maybe we should have understood, is we have found over and over in all our care experience working with the project teams, it actually changes the way care providers do their job. As soon as a care provider flips and understands that, view everything through the eyes of patient's family, it actually changes the way they do their job. And we make it very clear in this process that when we do shadowing, for instance, we tell them we're shadowing the system of care delivery, not the individual performance of each caregiver. Because we have seen over and over, 99% of the time at least, every caregiver is in there to take care of patients, and it's the system that gets in the way of us delivering ideal care. So we're measuring the system to help drive. The other benefit of this is it's amazing how caregivers, during the shadowing process, will tell our shadower suggestions on ways, right in front of the patients and family, how to improve the system. So now, not only are you engaging patients and families in the redesign, you're engaging the grassroots care providers in the redesign of the system. And we actually have we just developed an iPad shadowing app and platform to help teams develop and do this very, very quickly. So now I think we can rewrite the equation. And this is the rewrite the equation the way care providers would think about it, and patients and family. So now, if we have the patient and family at the center, the numerator becomes care experiences, clinical outcomes, quality and safety, and patient-reported outcomes. So again, we're not leaving behind anything that we've done, but the denominator now, you do have the tools to look at true cost. So we can begin to see how all these variables, how they all fit together. And as Diane mentioned, it's a win if we have high quality already and good experiences and good patient-reported outcomes, but we just reduce the cost. That's a win. So on a grassroots level, triple aim, I know, gets a lot of attention. A triple aim, to me, is a top-down. It's a very important tool, but when you're a grassroots provider, we're all like, show me. This is the way you have to do it. So we call it the value trifecta. The value trifecta is when you can deliver ideal care experiences, better outcomes at a reduced cost. And then care providers understand that. So just as a quick example, the center we built at McGee was really the first pilot project for this kind of thing. So I like to emphasize for especially care providers, this is a real thing. This isn't an abstract theory kind of thing. We really do this, and we've done it over and over. So we've tried, even before all the changes on the horizon, to always deliver value and move from the emphasis of volume to value. Okay? So when we do that, you start looking at where patients are discharged, and now 90% of all our patients, all comorbidities for primary joints, are discharged directly to home. We have the lowest length of stay, and now we have a tool that we actually measured cost, and we can begin to make the claim that we have the lowest cost too. We have transparency. We've published outcomes reports for 7 years running. So it's out there for patients to examine. And just an example of how this system can drive change, we've worked with John Waters, who's an anesthesiologist at Pitt that runs the blood conservation program at UPMC. And with many changes over the last 2 years, we've driven transfusion rates for primary joints from the level of 50 to 60% after surgery down to less than 1%. I actually just got my outcomes report for 2014, and for the first time, at least in our place, I had 0 transfusions for primary total hip patients. My partner, Brian Hamlin, had 0 transfusions for primary knee replacement in a year. And again, this is a systems approach. But when you think about it, this is the trifecta, because by doing that, people that aren't clinicians in the audience, we found that transfusions are literally bad medicine. It increases length of stay, it increases complications. There's all kinds of clinical reasons why not to do it. Patient satisfaction, it was great because we went from collecting blood draws every single day they were in the hospital to now collecting one after surgery, the day after surgery. Then you look at the cost part. So in surgery, we used to use special drains where we recycle the blood and put it back. We just stopped using that because the drainage was so low. And just in that stage, we saved over $76,000 a year. The next stage, we said, why, and this came from a patient actually, from our advisory council, why do you need to collect these things that they call types and cross and types and screens? Because we're not giving blood back anymore. So we first did away with the types and crosses, and that saved $240,000 a year on our volume. Then we did away with types and screens about a year ago, and that saved an additional $240,000. So this is the idea of outcomes, experiences, and cost, the trifecta. And historically, we have one of the highest HCAP scores in Western Pennsylvania for our unit. And I will say, the reason we have such good scores, and remember, these are hospital-based scores, but the reason we have these kind of scores is because we cover the whole experience. My patients, again, don't think of the hospital 2 days. They're only in the hospital 1 to 2 days now after surgery. This is what's supposed to measure their hospital experience. In their minds, they're thinking from the first office visit to that first post-op follow-up a month after surgery and everything that happens in between. So to drive HCAPs, you have to drive improvements in the whole experience. Isolated changes within the walls of the hospital may see some changes, but you're not going to see the dramatic changes. So then we flipped it, and I think our program was very cost-effective. We always looked at efficiencies and all the things we typically did. But then we said, well, how much does it really cost to deliver a primary hip or knee replacement to a patient? And it includes 1 month before the surgery and to 3 months after the surgery, which just so happens to be the bundle period that everyone talks about. So then you start looking at that, and these are the silos that one of my patients deals with when they have a hip or knee replacement. So the two silos, the physician's office and the acute hospital, are sort of the ones we always focus on, right? But it starts at home, goes through that, then it's health insurance, pharmacy, home health, outpatient therapy. Maybe they need to go to a skilled nursing facility, rehab facility. So I'll challenge you to think of any common denominator between all those silos except for our patients and families. So the only way to connect the care when you develop a bundling system or a care experience, an ACO, whatever it is, you have to follow the patient and family through. And now we have the ability to collect the resources at the same time. So we applied Bob Kaplan's TDABC approach to our program to achieve this. And I'm not going to go into a lot of the details. I'd be more than happy to talk more about it in detail. But again, you think of a 4-month experience, you have to break it up into smaller segments. So we broke it up into 7 segments and subsegments. And these are actually pretty generic for any surgical experience. So you can start thinking about it. It's not just for hip or knee replacement. So I'll jump to the results. So again, this is a 4-month bundle. This is true cost now, meaning resources, consumables, space, and equipment. And it's only the resources used to deliver that experience. So one of the surprising things, again, is it opens up your mind, and we always talk about, for instance, how expensive OR time is and expensive some of the equipment is. But it's a very small percentage of the whole. Personnel and consumables, and I was talking to Jamie before, any area where you're using a implantable device, it's going to follow this same model. So consumables actually was more expensive than the personnel. So then the benefit of this is you can start digging deeper and deeper. So now you can look at where are my resources going to provide care. So this is back to those 7 segments. And you can look at every step and say, where are my resources from that 4-month period being spent? Now, one important thing with this is, for instance, when we compared our program to other programs, we have a slightly higher front-end expense because we spend a lot of time educating patients, and we call them coaches. So we actually have more time up front, but you could think it provides benefits on the back end. Lower length of stay, early rapid rehab, all those other things. But again, it's the idea you can, for once, have a tool that's tightly coupled clinical and financial performance and start digging deeper and deeper. So as expected, what happens within the walls of the hospital is the most expensive segment. But then you can start digging deeper in the OR, again, as a surgeon, that's always the most expensive room in any hospital. But then you can break it down just within the OR now as those 4 buckets. And again, look how small the space and equipment costs are, where consumables now are even greater percentage than personnel. Do you know why that is? What makes the consumables so much more expensive than everything else? Yeah? Right. It's an eye-opener because now just the cost of the implant, and I sit on the implant purchasing committee for UPMC, where we've worked for Larry Crossan and others, Ted McLean's here, worked for 8 years on developing we think, a very competitive price for our implants. So I think we have and still with that, it's these percentages of the total consumables used. Then, that's just the OR. So now extrapolate that over a 4-month experience. The cost of just the implant in a 4-month experience for total hip is 40% and total knee 30%. Not sustainable when you start talking about reference-based pricing, bundling, care system. We can also now look at, again, remember this is all time dependent. We can look at the type of personnel and how much time do they spend with a patient in taking care of that patient. So most importantly, for a 4-month period, there are 47 categories of care providers involved in the bundle. Not people, just categories. Just within the hospital, there's 22 categories of care providers that take care of a patient. So think about if you're going to develop a team, how are you going to develop a team? Because you're cutting across that. But you can also begin to look at, Bob Kaplan's, one of his the phrase I always remember is that in this kind of situation, everyone needs to be working at the top of their license, right? Physicians should hand down things to nurse practitioners and PAs, who should hand down things to the nurses, should hand down things to medical assistants, to scribes. There's a flow of that. This gives you a tool to look at that for the first time. It's not just talking about it. One of the things we do that no one else does is we actually also track the patient time, their investment in their care. So a patient, and this includes the 4 months, this is direct care, or them doing exercise, for instance. We can tell patients now, it takes about 100 hours of their time to get through that time to do the care experience. We also look at unproductive time. It's the missing link. We always look at our efficiencies, but we don't look at the impact of our inefficiencies on patients and families and lost opportunities. So you can now track what's the unproductive time, meaning how long are they waiting in the office to see a doctor? How long are they waiting to get their surgery? How long are they waiting to get into therapy? And now we have extended this. It's a tool that you can begin to look at facilities too. So now we're looking at how does one facility perform the other in a structured way. So these are the same 7 segments. And you can say, what are the differences between the facilities? But not just the differences of the variation, but why? And then how can we change that? And you just use the patient-centered value tool. We just closed a national joint replacement learning community run by IHI, in which we applied these principles to over 32 organizations across the country, all high volume, greater than 200-year joint replacement centers, measured their outcomes, collected PROs and outcomes, and started this process improvement kind of effort. And one of the things that stood out, and Bob Kaplan's going to be publishing a paper in Health Affairs, is even with high volume centers, the variation just in the implant cost was over 8 times from the cheapest to the most expensive. And he provided some suggestions, our learning community suggestions on ways to improve that. So some samples of value projects that we're undertaking. We're looking at 23-hour joint replacement and whether that really has a value, looking at outcomes and costs. Rehab, if they have to go to a skilled nursing facility, We're working with a OB group at McGee on hysterectomy experience with or without robotics. So again, circling back to the initial theme, is that I think we do have the opportunity to develop a truly patient-centered value system that can become your new operating system. And it's one tool that you can develop a team to implement that change. But it really starts with the patient being in the center and connecting all those buckets. And this is really, to me, how we can compete, or it's the how-to. If you are going to develop, think about it, although we didn't intend it, we're perfectly positioned to participate in a bundling or a reference-based pricing system. It also can look at direct contracting, but also as a cost reduction tool. You don't have to always participate in one of these new models to look at efficiencies of care and outcomes and quality and cost. So but it's a thoughtful cost reduction tool. It's not a sort of cut your budget from 10% down, top-down kind of thing. It's hopefully giving the care providers tools to do that. So there's a saying, no margin, no mission. Does anyone know where that came from? I thought it came from Bob Kaplan, but he stole it from Sister Irene Krauss, who started the biggest Catholic healthcare system in the United States. And she took this, if you read her biography, she took this to heart. And they had a mission, but she understood you're not going to be able to achieve your mission without having that margin. And what this approach does, as I mentioned, couples clinical and financial performance. You have the patient focus, which is our mission that coincides for transformation as a change agent for transformation. It generates a sense of urgency and the teams necessary. And the ultimate goal is to change the culture. And that's always the hardest thing to do. But I will say, from a grassroots level, we're all buffeted by all these different factors. And our position is that if we return back to our mission, which is the patient and family, all these other things will help be able to take care of themselves in the new world. So with that, I'd like to close my talk, and then if we could have all the speakers come up,